Primary sclerosing cholangitis is a chronic liver disease characterized by inflammation, fibrosis, and destruction of the bile ducts, both within and outside the liver. This condition leads to cholestasis, formation of the bile duct strictures, and hepatic fibrosis, which in turn may progress to cirrhosis with portal hypertension. Primary sclerosing cholangitis is a rare disorder which has a strong association with inflammatory bowel disease, especially ulcerative colitis. So, to understand this disorder, we have to discuss the pathogenesis step by step. The first step in pathogenesis of primary sclerosing cholangitis is the transition from normal state to preclinical stage. This transition is driven by microbial dysbiosis and activation of immune system. So let's illustrate this. So here we have a bile duct. As we know, liver secretes into the bile duct cholesterol, bilirubin, and bile acids. All together they form normal bile. Here we have intestinal lumen where intestinal bacteria are located. Sometimes, especially with inflammation in the intestine, bacteria can leak through the barriers into the soft tissue. And bacteria on their surface have some glycoproteins that we recognize as antigens. Immediately after bacteria leaked into the soft tissue, our macrophages phagocyte bacteria and present bacterial particles on MRCP receptors to T helpers. T helpers scan bacterial particles, and because of antigenic material, in response to this, they become activated. And once T helpers becomes activated, they activate B lymphocytes. With activation, B lymphocytes begin to produce antibodies against antigens on bacteria. But in primary sclerosing cholangitis, the MRCP receptors may present these particles in an unusual way, and in this scenario, bacterial glycoproteins can look very similar to glycoproteins on biliary epithelial cells. And this leads to a phenomenon which is called molecular mimicry. Basically, in these circumstances, T helpers tell B lymphocytes to produce antibodies not just against bacteria, but also against glycoproteins on biliary epithelial cells. So, B lymphocytes begin to produce autoantibodies which target biliary epithelial cells. It's antinuclear antibodies, peripheral antineutrophilic cytoplasmic autoantibodies, and antibiliary epithelial cells antibodies. These autoantibodies cause inflammation of the biliary epithelial cells, which results in their destruction. As we see, the most prevalent antibodies in the serum of patients with PSC are PNK and antinuclear antibodies. So, after activation of immune system, the production of autoantibodies cause inflammation of the biliary epithelial cells. As disease progresses, inflammation causes activation of hepatic stellate cells and portal myofibroblasts, which begin to produce connective tissue. And massive production of connective tissue results in formation of onion skin fibrosis, which will cause stricture of the biliary duct. Exactly this fibrosis in the biliary ducts is the hallmark of this disorder, and it's exactly the reason why we call it sclerosing cholangitis. So let's illustrate this. In the soft tissue, we have fibroblasts and hepatic stellate cells, which in normal condition produce a mild amount of collagen. But with activation of B lymphocytes, they begin to produce transforming growth factor beta, which activates fibroblast and hepatic stellate cells. In addition to this, T helpers activate macrophages. Macrophages with activation also begin to produce transforming growth factor beta and interleukin 6, which activate both fibroblast and hepatic stellate cells. With activation, fibroblasts become myofibroblasts. Once both cells are activated, they dramatically increase the production of collagen fibers. And this progressive deposition of collagen fibers in subendothelial layer eventually leads to narrowing of the bile ducts, and with time, the more collagen fibers are produced, the more narrow becomes the space in the bile duct. The problem here is that with decrease in radius of the bile duct, the bile flow decreases, which will cause inability to excrete bile into the intestine, and this state we call cholestasis. So let's illustrate this from a different view. So here we have a bile duct. Inside the bile duct there is bile, and within the walls of the bile duct there are fibroblast and hepatic stellate cells. With inflammation, both hepatic stellate cells and fibroblast becomes activated, and in response to this, they begin to produce connective tissue. This progressive deposition of connective tissue begins to narrow the lumen of the bile duct. With time, as inflammation progresses, the deposition of collagen fibers also progresses, which leads to progressive decrease in radius of the bile duct. This progressive deposition of connective tissue, as we see, occurs in onion-like pattern, and that's why in the books you can find definition onion skin fibrosis. On this image we can see progression of primary sclerosing cholangitis from histological perspective. On image C, we can see onion skinning fibrosis, which is a hallmark of this disorder. As we see, the bile duct lumen is very small, and on image D, we can see complete obliteration of the bile duct. Basically, bile duct becomes replaced by connective tissue, and obviously such bile duct cannot provide bile outflow. To explain why cholestasis develops, we have to recall physics. Recall that bile flow is equal to pressure difference divided on resistance, and resistance is inversely proportional to the force power of radius. So what happens is that with fibrosis, radius decrease, this causes increase in resistance, with increase in resistance, bile flow decrease, and with decrease in bile flow, cholestasis develops. Here we can see normal bile duct, and on next two images we can see inflamed bile ducts with progressive sclerosis. Eventually, on image C, we can see that sclerosis causes formation of a stricture, which will cause significant decrease in bile outflow. What are the clinical consequences of this stricture formation? First of all, because we are not able to excrete bile acids, bilirubin and cholesterol, they begin to accumulate proximal to the obturation, and with time they begin to leak into the blood through the biliary epithelial cells. Also, with destruction of the biliary cells and with cholestasis, biliary enzymes begin to leak into the blood. This causes increase in concentration of alkaline phosphatase and gamma-glutamyl transferase in the blood. Based on this pathogenesis model, now we can see why patients with inflammatory bowel disorders are at risk. Simply because any inflammation in the intestine can affect the permeability of the intestinal and biliary epithelium. And the more permeable are the barriers, the higher is the risk of bacterial translocation, and thereby the higher is the risk of primary sclerosing cholangitis, because as we see, this disorder is triggered by bacterial antigens. Now let's discuss how primary sclerosing cholangitis causes clinical symptoms. As we know, primary sclerosing cholangitis causes autoimmune inflammation of the small, medium and large bile ducts. Inflammation causes damage to biliary epithelial cells, and damage leads to massive fibrosis that results in obturation of the bile flow. Bile flow obturation causes increase in blood bilirubin level, which leads to jaundice. Also, with bile flow obturation, the outflow of bile acids decreases, while the level of bile acids in the blood will increase. With decrease in outflow of bile acids, the amount of bile acids in the intestine decreases, which will affect fat absorption. With decrease in fat absorption, steatorrhea develops, and also without bile acids we cannot absorb fat-soluble vitamins, as vitamin D. As a result, patient has increased risk of osteoporosis. With bile flow obstruction, we cannot excrete cholesterol. As a result, the level of cholesterol in the blood increases. This leads to deposition of cholesterol in the skin with formation of xanthomas, and deposition of cholesterol in the eyelids with formation of xanthelasmas. Damage to biliary epithelial cells also causes leakage of biliary enzymes into the blood, which leads to elevation of alkaline phosphatase and gamma-glutamyl transferase, which are important diagnostic criteria. As we know, autoimmune inflammation occurs by production of antibodies, as ANA, PIANKA, and antibiliary epithelial cells antibodies. They all are immunoglobulin M antibodies, and antibodies belong to gamma fraction. So the elevation of immunoglobulin M antibodies in the blood with increase in gamma fraction of proteins on electrophoresis is important diagnostic feature. With time, inflammation can spread from the bile ducts to the liver tissue, which will cause liver injury. Liver injury can be diagnosed by increasing ALT and AST in the blood, and progressive liver injury leads to cirrhosis. In cirrhosis, liver cannot produce enough proteins into the blood. This will cause decrease in albumin's production, which will cause edema. Also, with cirrhosis, the production of thrombopoietin decreases, which leads to decrease in platelets level, and decrease in platelets can significantly increase the risk of bleeding. In addition to this, we know that decrease in bile acid outflow disrupts the absorption of fat-soluble substances, and one of such substances is vitamin K. Decrease in vitamin K absorption also leads to a higher risk of bleeding. In addition to this, in cirrhosis, massive fibrosis leads to veno-occlusive syndrome, which in turn leads to portal hypertension, and portal hypertension manifests with shunt formation. Clinically, we can see this as formation of esophageal varices with varicose bleeding, also by caput medusa or by hemorrhoids. Also, portal hypertension frequently causes hepatomegaly and splenomegaly. Among diagnostic methods, we can use ERCP, but the golden standard and the correct answer on examinations is MRCP, which is magnetic resonance cholangiopancreatography. Also, we have to know that this disorder can progress to secondary biliary cirrhosis, and it can significantly increase the risk of cholangiocarcinoma and gallbladder cancer. Currently, the treatment of choice is ursodeoxycholic acid.